considering that, in the long case, sometimes, quite often you will know that you are prepared for a hip case, but still some of the boys find it challenging. This could be because some cases are difficult, and being long case, you have many special tests. Management may be controversial, and time factor. That's another common complaint, that we are not able to examine and write everything. Now, probably the answer for all these things lie in following a regular protocol or steps in examination of a case. I'm sure you will know all this. My talk will be in general. As you heard from about the modules, you have another webinars on examination of hip, examination of spine. So I'm not going to talk in relevant to any joint, but generally what are the steps that I was taught, what I learned, and what I follow and what I teach. So this is not going to be different from anything that you follow, but there could be minor differences. Like we start with the history, which we heard, general examination, then gait. Gait could be in the beginning, gait could be later. It doesn't make a difference. I prefer it beginning because in the end, if you run short of time or you forget, you may easily forget it. So that's why I kept it beginning, and I prefer it in the beginning. Then comes the regional examination, local examination, which is inspection, palpation, deformity assessment, assessing the range of movements, measurements, different types, special tests, other joints, spine, neurology, and review. Now, why do we need a protocol like this? The two things. Like we just heard, history is an art. Similarly, examination is something which you can perfect yourself only by practice. And when you practice, if you follow a step, automatically you do it for 20 patients, 21st patients. If you come to you without thought, you will not lose time. You can save your time, and habits, once you have a habit, it will naturally go. Now, history we already heard. That's what I was wanted to add, but unfortunately, I think they couldn't see this thing. Now, history can be very important for you in the examination and also in the diagnosis of some conditions. Like rheumatoid, history plays a very important part. The difference between spinal and muscular claudication, history plays a part. And at the end of history, the examiner will ask you, what do you think from the history? You can get stuck at that stage. If you get stuck at that stage, you will lose your confidence, you lose your, that continuation of thought. So you take history important. I just want to give you one more point before I go to examination. When I take a history, I always think three components may not be applicable in every case. But if you take an example at tuberculosis of the spine with a paraparesis or paraplegia, I will take history suggestive of the primary tuberculosis. What are the points in the history in favor of tuberculosis? So, like whatever it is, loss of weight, loss of appetite, history of chronic cough, like that, and history of the region. Back, okay, what about the back? What are the related to that? The pain or disability? And lastly, you have a complication, you have a neurological problem, history of that, including bladder bowel. So, if you divide like that, when you justify your history, it will be easy. That's why I want to go with that. Coming to clinical examination, the most important thing, you should know your anatomy. Spine, hip, shoulder, whatever be the joint, foot and ankle, you should know your anatomy. Coming to general examination, in orthopedics, lipidopathy commonly we include in general examination. So whatever be the case, don't forget to examine for lipidopathy. Second thing is, look at the patient. Don't look at the examiner even when you are presenting. Look at the patient, because if you are touching him, if it is painful for him. Even before that, in general examination, if he is having a visible facial expression of pain, be careful. At no stage we have no reason, no authority to give him more pain. So whatever you do should not be painful, to be gentle to the patient. The examination starts for me with gait, and gait is not a very simple thing. I am not going to cover gait here. You will have another talk on that. I am sure Manish will have already planned that. Gait, I found it very difficult to make out what the gait was in my student days. What's the Atalji gait, lumbar gait, everything has got, a gait cycle is something in which you have to assess many factors. A main change in gait, there are 6 major determinants: a pelvic rotation, pelvic tilt, the knee and hip coordination, the knee and ankle interaction, and the foot lateral pelvic displacement, stride length, step, so many things. All these irregularities are what gives you the clue of your diagnosis. And the entire gait cycle is over in a few seconds. And if you are going to find out in that time, again it needs practice. Unless you keep seeing it regularly in the OPD to make sure when you see a patient with unstable hip, see the gait, understand, take it, that's the only way you learn. That's all I'm going to say about that. Coming to the examination, as all of you know, it starts with the inspection. Inspection for me, I divide into 5 things. Which 5 is the first one is the attitude. What is the position you see? It may not be a fixed deformity. It's the attitude. Inspection, you can't say that. But whatever appears there, what is the position? Whether it may be a wrist drop, it may be a foot drop, it may be a flexion, abduction, rotation deformity, whatever that, you look for that. Then look at the limb length. Relevant bony points. Please remember, all the bony points in whichever region may not be visible. Visible, relevant bony points. Then the soft tissue, you look at the changes in the skin, if there are swelling, sinus, scars, etc. And lastly, look at the wasting for the muscles. Please remember, wasting is something better seen by the eye than measured. Your eye is capable of appreciating a wasting, particularly if you have a contralateral muscle which is normal. And this is where you have to tune your vision for that. It comes from experience. Extra inspection has to be patient from the front, side, back, maybe in sitting, standing, and lying down position. All this is important because certain things. If at all you take a spine, from the front you can see a pelvic tilt. From the side you will be able to see a kyphotic and a lordotic deformity. And from the back you can appreciate scoliosis. So like that, for each area, it is important that you should not forget. In the attitude, when you have an attitude, you should know the relevance. What the mind does not know, the eyes will not see. So you have to have idea. For example, rhinitis of the hip can produce the deformity. Arthritis will produce the opposite deformity, flexion, adduction, internal rotation. Same thing can be there also in a posterior dislocation of the hip. But remember, all deformities of a joint need not be because of intra-articular pathology. In our student days, one of the common problem we used to have was a psoas abscess. And that patient may have a flexion deformity of the hip. So that is so, you always remember there could be extra-articular pathologies also. Some of these deformities are terrible. Your diagnosis clear from them. Whether it is going to be a rocker bottom deformity, whether equinovarus deformity, Taylor's deformity, or a deformity of the lower leg, all these deformities. Again, important thing is you look at the deformity. If you have another contralateral leg or equal part normal, you can compare. Swellings, you learn to describe the swelling. Swelling can be diffuse, it can be localized. A swelling which is diffuse may not be due to orthopedic pathology. A localized swelling, if it is over the joint, you will think of a joint pathology. A swelling which is along the course of a tendon, maybe a tendinopathy. And if you find a swelling with the ecchymosis like this history of trauma, you will think of some traumatic etiology. These are not the only things. You look at the skin, if you find hypertrophic nails, decreased hair growth, the skin is shiny, and you all can indicate the porous surplus. So many things can be seen by
Rajagopalan sir? Rajagopalan sir?
Yes, yes.
Sir, is there any other device through which you have opened it? Open the Zoom meeting, because there is a lot of disturbance from your side actually.
So what happened was, in between, my power went off here. My power failure in Pondicherry. So I went into my mobile to see that time.
Okay, sir, please switch off that. Please stop the sharing. Stop that, sir. Actually, that's creating a problem there.
Okay, sorry. What happened was, that time when during the question answer time, there was a power break here.
Okay,
so I couldn't see anything. And so I went into the mobile and saw. I forgot to switch it off. Now I switched it off. It is put off now.
Also, sir, are you using any microphone or earphone wire in your laptop?
No.
Sir, you can try. You can try using microphone better. Otherwise, just let it try.
Audio is not adequate.
No.
I tried with the microphone. It was not better.
Okay, then it's okay, sir. Move on, sir.
You can mute everyone
Sir, everyone is muted actually.
except
Yeah, except sir.
Rajagopalan sir, you can proceed. You just let your face be nearer to the computer. That's all.
Okay.
Please proceed, sir.
So coming to the palpation again, when necessary in supine, lateral and prone position, it always starts with the local rise of skin temperature, local warmth compared to the opposite side, and areas of tenderness. It is not just the joint, the relevant bones, adjacent bones, specific anatomic landmarks relevant to that joint, and always follow a method of palpation, a systematic method, so that you do not miss any part. You should cover all the involved bone, soft tissue, and then you will have a local examination specific to the case. For example, if you take a shoulder, your shoulder palpation will not only just include the humerus and the glenoid, it has to include sternoclavicular, clavicle, like that. You have to plan. You have to know it is not limited to just the one area. And why do we want to see in a different position? Sitting, standing. Look at these pictures. If your patient is the one with a genu varum or a genu valgum, your standing may increase the deformity. And also the limb alignment is very, very clear. And why do you want to see from the backside? If from the backside, if you see the leg and the heel alignment, you can easily make out a heel varus or a valgus. The local examination specific to each joint, like you can have a vascular sign of Narath or palpation of Scarpa triangle in the hip, popliteal fossa and axilla in the and patella in the knee and axilla in the shoulder, like that. Each will be specific to each joint, so I won't go into that. A few words about deformities. In a hip case, you know, you are all prepared mentally. Whatever be the case, that's a deformity of the knee, or it may be not a joint problem per se, it may be a post-poliocerebral paralysis deformity or a CP deformity. It is just not knowing the test. You may know a Thomas test, but more important for me, you understand the principle of radius. If you are going to flex the hip for correcting the lordosis, why I am doing it, I think that is what is very, very important. Then coming to the range of movements. Quite often in the examination, the findings of the examiner and your findings do not match. It may be because either your findings are wrong, sometimes patient may not be cooperative, but quite often it is also possible that your findings are wrong because you have not been doing it regularly. There is no controversy or trick in movements. It is a question of practice. How you are able to practice, particularly if the patient is having a spasm, without his knowledge, the joint movements will come down unless you make him relax and take him their confidence. And be gentle with the patient. Suddenly don't go and move. That is the patient, he will develop a spasm. Learn to be gentle with the patient, and most important, learn to use the goniometer. You will say 60 degrees, and I examine 30 degrees. I will say check out your goniometer. You will not know how to use it, you will be fumbling. So learn to use the goniometer. Always do the active movement first. Because if active is painful, you be careful. If you are passive, patient will be more apprehensive. If it is not painful, then you can still do gently without pain to the patient. And examine the opposite limb in identical position. Now, measurements, apparent measurements, real measurements, I'm not going to that. But invariably, you forget measurements in the upper limb case. Measurement has been done for any upper limb, severe problem, knee problem. Everything has to be done. And again, when you do special measurements like a branch triangle or a Mertens line, please remember, again, understand the principle behind it. I know these lines are drawn only in the body, they are not in the skeleton. But take a skeleton, touch the body points, get the feel of it, see what is the anatomy that you are having behind it. If you just even see one pelvis once like that, everything will stay in your mind. You understand why ischal tuberosity is a broad area. It is not easy to, it can always be going wrong with the Mertens line. Special tests are many. All of you, postgraduates will know You will be prepared for special tests in hip, Schauber's test in measurement in spine, but in the exam, you might forget. So there's one thing that I usually do. Let's, for example, take a shoulder. There are so many tests for impingement, labral test, instability test, etc. You can't remember them every day. There are two things. Whenever you have a shoulder patient or a hip patient in the ward, whenever you have a time, examine it like an exam base, do all the tests, you will learn. Another thing is, you make a chart. Here I have made a chart of 12 tests for shoulder. A similar chart you make for different joints. Make a big poster, put it in your classroom. Every day, if you say good morning to others, come to the poster also, say good morning, read it once. 10 days you do it, 11th day it will go into your brain without your knowledge. Once you have examined the joint for other things, then you go to the joint above and below, opposite joint, circular joints and spine, don't forget, chest expansion, neurology. After doing the neurology and spine, now you may think, I forgot something. I forgot to palpate liver spleen, or I forgot to do chest expansion. You can go back and do that. Once you have finished all that, the next step is summarizing your case. Summary is again you need practice. It is not repetition of all your findings. If all your tests came to a conclusion that this hip is a bony ankylosis, this is a fibrous ankylosis, or this is an unstable joint, you can summarize your findings rather than repeating the findings. Once you do that, once you give a provisional diagnosis, the examiner may ask you, what's your differential diagnosis? If just because we ask, you don't have to give a differential diagnosis for every case. If all your points are in favor of your diagnosis, let's say your diagnosis per piece and all cases are in favor of it, there's nothing against, you don't have to give a DD. But if your points are against it, then you have to give a possibility according to that. And when you give a diagnosis, at least in some centers, they expect you to give an anatomical diagnosis, pathological diagnosis. Take a scenario when you have say a chronic arthritis, say a single knee joint involvement, chronic duration. Your anatomical diagnosis, if it is chronic monoarthritis, your pathological diagnosis may be tuberculosis. Or if it is going to be a chronic polyarthritis, it may be an inflammatory lesion, you may say rheumatoid or angular spondylitis. So you can put like that whenever possible. And because once you give a diagnosis of say chronic arthritis, probably tuberculosis, then the examiner will ask you what are the points in favor of your diagnosis. So you can say the points in favor of chronic arthritis, points in favor of your tuberculosis. And remember the findings that are against your diagnosis and think of DD for those. Once you have given your differential diagnosis, the examiner will ask you, how do you proceed? If you have time after your presentation, there's a time you write down your investigation, nothing wrong with it. Nothing wrong with it. But when you are asked, think before you talk. You are going to ask for an MRI, and they ask you why you want an MRI, and you are not able to answer that, it reflects poorly on you. So be prepared for that. And once you have given the diagnosis, the next will be what's your management. Quite often you will say, I can do this or you can do this. That's not the question, is what will you do? For one patient, you can do only one management. You can't do 10 managements. So you plan already in your mind and give what diagnosis you want to do, what management you want to tell. In case you have 2-3 options you do not know, not sure, then give the management that you have seen for that condition in your own institution. That will be the best if you do not know what to do. I have not gone into all the details. This was a basic starting one. I have just given you the various steps. And that similarly for the other, each joint there will be different talks. But what is important for you is, if your presentation has to be definitely impressive. And that needs perfection. And perfection comes from practice. For that, follow a systematic method in clinical assessment. So good luck to all of you in the exams and have a nice day. Thank you.